Hey guys, so today we're going to do a little ABG interpretation review. So I'm going to share my screen so you can see a presentation that I put together. And this is something that I actually put together when I first got started here, and we were kind of in the middle of COVID. And so I just wanted to review it. I think ABGs are really, really interesting, but I didn't really fully grasp them for the first couple of years that I was working because I never really sat down and broke it down into all the different pieces. And I would see my other nurses and providers and respiratory therapists being able to look at an ABG and be like, oh yeah, this is exactly what's happening and how we treat it. And for me, it was always like, what is it? What am I missing? So I just wanted to go through some of the basics and do a little bit of background and a little bit of interpretation practice, figure out if maybe this is a helpful way for you to be able to read ABGs. So to get started, what do we have in a normal ABG? We have our pH, our CO2, and our bicarb, which is our HCO3. Those are the three main things that we really care about. And so our CO2, you can see here on the slide, our CO2 is related to the lungs, right? And so when your pH gets out of whack, your body wants to try to compensate it to bring it back into a normal range. And so that's either the lungs, which you see here with the CO2, or that's with bicarb, which is with the kidneys. And both of the lungs and the kidneys are able to manipulate CO2 and bicarb to be able to try and bring that pH back into a normal range. So you can kind of review this. We're going to talk a little bit more as we go on about retaining and blowing off CO2, and same with bicarb. But one thing I want to point out here is carbonic acid. So this is an equation I actually didn't know about until just a couple of years ago. It wasn't something that was ever taught to me as to why I should care about what this reaction is. And I'll tell you why I care in just a minute. So carbonic acid, H2CO3, it's an unstable acid. So what happens is it wants to try to break apart, and it wants to convert either into bicarb and a hydrogen atom, or it wants to convert to carbon dioxide and water. Why do we really care? Primary reason we care is because of this bicarb piece. Okay, so let's say we've got a really acidotic patient. So that acidotic patient has a lot of excess hydrogen ions. It's an acid. Okay, now in our mind we know, oh, bicarb's a base. If I give bicarb, then I'm going to fix the acidosis. I'll bring that pH up, and then the patient's going to get better. Not quite. So look what happens here. You give bicarb to a patient. Okay, they combine with that hydrogen, all of the free-floating hydrogen ions. Since it's such an acidotic environment, it's going to convert to carbonic acid. Doesn't want to be carbonic acid, excuse me, for a long period of time, right? So then it converts to CO2 and water. Well, what does that mean for us? Doesn't mean anything bad if you are ventilating your patient appropriately. So this is where I sometimes get a little frustrated with the amount of bicarb that we tend to give to either patients that are acidotic or in arrest. Because if we're ventilating at a normal person's rate, so say 12 to 16 breaths per minute, we're not blowing off enough CO2 to be able to actually increase that pH. So all that bicarb that you're giving, okay, all that bicarb here on the right is quickly converting into CO2. Well, we're not blowing that CO2 off very quickly. Now, CO2 is acidotic, so that's going to start to build and build and build. And what we see is we see a lot of bicarb given in a short period of time. We see inadequate ventilations associated with that. And then what ends up happening is our pH actually gets worse because we're not blowing off all of that excess CO2. So that's why a lot of providers, especially if they have a gas ahead of time, if they see that bicarb is in a somewhat normal range, or at least in the double digits, they won't give amps of bicarb because it's just going to immediately be converted into CO2. So there's my little soapbox. We're going to talk a little bit more, though, about some of the specifics and how long this takes. But I just wanted to kind of throw that out there. That's why it's so important, is in some of these patients, we're actually going to make them worse, not better. So how long does it actually take for the compensation to occur? So respiratory, lungs, CO2, right? Think of all of those pieces together. That can happen within minutes. Think about your narcotic overdose. Stops breathing. Because they're not breathing, they're not blowing off CO2. CO2 starts to build up in their body. Their pH starts to drop. It gets more acidotic, worse because CO2 is an acid, so that pH starts to come down. And you can see that process happen within 5 to 10 minutes, right? You have them come in, they were just found, and they can already have a really low pH. So the respiratory side can happen really, really quickly. The reverse is if somebody is overventilating, right? They can actually cause an alkalotic experience, so they blow off too much CO2, and that can happen with a short period of time. Kidneys, though, they take about 2 or 3 days before they're able to either reduce or hold on to more bicarb. And so we'll talk about it a little bit later, but if you can see that there's bicarb changes on your ABG, you know that this process has been going on for at least a couple days, because it's given the kidneys enough time to kind of wake up and say, oh, we should probably join the party and try to do something to fix this pH too. So that's going to give you a little bit of information there as well. Talking about normal and what normal is. So pH, we've talked about a little bit already, talks about how many hydrogen ions are in the blood and determines if it's acidotic or alkalotic. Okay, so the normal you can see here on the graph, 7.35 to 7.45, that's the sweet spot. That's where we want to be. Okay, our CO2, carbon dioxide, that tells you if the lungs are involved in the problem, and the normal is 35 to 45. Okay, now the lower that number goes, the more that you're blowing off. The higher the number goes, the more you're retaining. Okay, bicarb tells you if the kidneys are involved, right? Normal is 22 to 26. That's kind of your sweet spot range for your bicarb. All right, so let's talk about how we actually interpret an ABG. So first step, you want to look at your pH and you want to determine if it's acidotic or alkalotic. So remember we said normal pH is 7.35 to 7.45, okay? So a pH of less than 7.35 is acidotic, okay? Anything less than that number is starting to get lower and lower, that's acidotic. A pH of greater than 7.45 is starting to become alkalotic, and the higher it goes, the more alkalotic it becomes. So that's an important place to start. We need to determine if we're acidotic, alkalotic, or normal. Okay, step 2, look at your CO2. All right, you want to figure out what the primary problem is. So if your CO2 is in a normal range, 35 to 45, great, we're all set. But let's say our CO2 is less than 35. Okay, that means that the body's trying to blow off some extra CO2. Okay, let's say our CO2 is greater than 45. That means that the body's holding on to CO2, right? It's starting to rise. So there's one thing that's really helpful, and I'm going to talk about it right now because it has this little star thing saying if the PCO2 moves in the same direction as the pH, primary cause is metabolic. And I'm going to explain that a little because I think it's kind of confusing sometimes. So Rome is something that I like to use. It's called respiratory is opposite, metabolic is equal. Okay, and that's looking at your pH and your PCO2, just those two numbers. So if you're having any type of a primary respiratory problem, what's going to happen is you're going to see the pH and the PCO2 going opposite directions. Okay, and that's regardless of if it's pH down, PCO2 up, or pH up, PCO2 down. Okay, they're moving in opposite directions according to these arrows. If it's a metabolic problem, then you've got your pH and your CO2 moving in the same direction, either going up or both going down. Okay, so that's why it's important in step 2 to kind of keep in mind, well, just because the PCO2 is off doesn't actually mean it's a respiratory problem. It can actually be a metabolic problem with a respiratory component. And that's where we start getting into compensated and uncompensated, but I'm going to clear it all up for you. So let's just move to step 3 real quick. Look at our bicarb. Is it normal, 22 to 26? Is it less, okay? Or is it higher? Okay, so even if it's a primary respiratory problem, if your bicarb's starting to get involved, there's some metabolic relationship there that's going on. So I'm going to show you how we can differentiate between who's the primary problem and how we better treat that. So again, you can see the Rome method, opposite, respiratory opposite, okay, for pH and CO2, metabolic equal for pH and CO2. All right, talking about the confusing compensated, partially compensated, uncompensated. This part used to get me like crazy, but we're going to try to break it down and make it a little bit more simple. So compensated, okay, that means that our pH is normal. We look at our gas and we say, wow, our pH is normal. But my PCO2 and my bicarb are both really off. Those aren't normal at all. Well, that means that the lungs, CO2, and the kidneys, the bicarb, did their job and got the pH back into a normal range, okay? So that's fully compensated. The lungs and the kidneys fully did their job and got the pH back to where they wanted it to go. So let's talk about an example. So if we got a pH of 7.35, okay, that's normal, right? Because it's between 7.35 and 7.45, so that's normal. Our PCO2 is 62, so is that high or low? It's high. And our bicarb is 40. So is that high or low? That's also high because normal is 22 to 26. So our PCO2 is high, which tells us that there's a respiratory acidosis going on, right? Holding on to CO2, that's respiratory. High CO2 is an acidosis. But we look at the bicarb and that's a lot higher than normal. So it's trying to compensate for the fact that there's a high PCO2. So it's holding on to bicarb to see if it can help to bring that pH back down. So because the pH is normal, fully compensated, so we have a fully compensated respiratory acidosis, okay? Let's look at partially compensated. So in partially compensated, not a single thing is normal. pH is wrong, CO2 is wrong, and bicarb is wrong. They're just all outside of range. And that means that the lungs or the kidneys are trying to fix the problem, but they haven't fully fixed it yet, which is why they're abnormal and the pH is still abnormal. So here's a good example. You got a pH of 7.25, okay? So that's high or low. It's low because normal range is 7.35 to 7.45. All right. Your PaCO2 is 25. High or low? Low because normal is 35 to 45. And your bicarb is 14, which is low because normal is 22 to 26. Okay. So you can tell that pH is down, okay? CO2 is down. And what do you have when you've got pH and CO2 moving in the same direction? Metabolics equal, got a metabolic problem. All right. So we know that it's a primarily metabolic problem. All right. That low bicarb is telling us it's an acidosis, right? Because that's base. So if we've got a really low bicarb, we don't have a lot of base. So if we don't have a lot of base, then we have an acidotic problem. Okay. The CO2 is low because the body's trying to blow off CO2 because we know we're acidotic because we don't have enough base. We know we're acidotic because our pH is low. So the lungs are like, well, hey, if I have acid in terms of CO2, I'll just blow it off. And then maybe I'll be able to actually bring that pH up and get rid of some extra acid to be able to fix this problem. So on this one, because all of our ranges are off, we have a partially compensated metabolic acidosis, okay? All right, let's talk about uncompensated. This is our last type. Uncompensated is when the pH is abnormal, but only one of the other two items is abnormal, either CO2 or bicarb. And why is that? That's because the body hasn't had time to try and correct the problem or compensate for the problem. All right, so here's a good example of this. And this, think of your narcotic overdose, okay? Was just found, was apneic, and unable to breathe appropriately, right? So what do we need to do? And how do we figure it out? So our pH, 7.3, okay? So that's low because normal is 7.35 to 7.45. Then we've got our CO2 is 55, so that's high because normal is 35 to 45. And our bicarb is 24, which is perfect because our normal is 22 to 26, okay? So we know our pH is acidotic and it's low, so our pH is moving down. Then we know our CO2 is elevated because it's high, right? It's 35 to 45 and this is 55, so we know that's up. So moving in opposite directions. So we know we have a respiratory problem. So if we have a respiratory problem with a low pH, the respiratory acidosis. And when we look at our bicarb, we can see the bicarb's normal. So the kidneys aren't doing anything to help fix the problem. They're not involved at all. So this is a uncompensated respiratory acidosis, okay? Because we know our lungs are involved, we know we're acidotic, and we know our kidneys aren't involved because the bicarb's in a normal range. Okay, let's do some practice ones. So start on the top left, and you can see the answer on the bottom. So try to do it without looking at the answer first if you can. But pH, 7.56. Okay, so that's high. All right. Our PCO2 is 20. That's low. And our bicarb is 20. That's low. Okay, so doing our step one, we see that our pH, because it's high, is alkalotic. So we know that our problem is going to be an alkalosis. Okay. We've got a high pH and a low PCO2. So we're moving in opposite directions. So if we're moving in opposite directions, respiratory opposite, we've got a respiratory problem. Okay. But then when we look at the bicarb, we can see that the bicarb is also low. So the kidneys are trying to help. They're trying to compensate. So we have some compensation there. So that means that we have a partially compensated, the kidneys are trying to help, respiratory alkalosis. Okay, all right, we're getting there. Let's do another one. pH, 7.25, low, right? PaCO2 of 60 is high. So right off the bat, we know a low pH is acidotic. We know if they're moving in opposite directions, it's a respiratory problem. Okay, so now let's look at our bicarb. Our bicarb's 30, is that high? No, that's actually a little high. So the kidneys are trying to get involved. They're trying to do something. Okay, so we know we've got our acidosis. We have our respiratory because we know they're moving in opposite directions. And our bicarb is high because it's trying to help compensate. Okay, but again, our pH isn't in a normal range, so it's not compensating enough to fix the problem. So we're still only partially compensated. So that's where we get a respiratory acidosis with partial compensation, because we still haven't gotten to the point where we can fix that pH. So we're still only partially compensated, but the kidneys are trying. They're at least getting involved. All right, another one, pH of 7.23, low. And then we've got a CO2 of 37. It's actually normal, right? 35 to 45. So now we're like, oh, okay, well, I got the one piece. Let's see what else we've got. And our bicarb's 18. So our bicarb's low, right? Normal's 22 to 26. Our bicarb's actually a little low. So you can see here that we've got a normal PCO2. So that's telling me lungs aren't really doing anything because they're totally normal. They haven't had to change anything. But my pH is low and my bicarb's low. So because I know my lungs can't be involved because my CO2 is normal, I know it's a metabolic problem. So now when I look at it, I can see it's acidotic, it's metabolic, and my CO2 is not involved at all. So it's not compensating at all. So I have an uncompensated metabolic acidosis. Okay. All right. Last one, pH is 7.37. That's normal. So we're like, whoo, okay. But our PCO2 is 31. So normal is 35 to 45. So it's a little low. And our bicarb is 17, which is also low, right? 22 to 26 is only 17. So you're like, okay, so what's going on there? So we have a pH that's in a normal range, but we have both of our other factors, our bicarb and our CO2 are abnormal. Okay, so both are trying to help fix the problem. Now, if you look at your pH, even though 7.37 is normal, if you think 7.35 to 7.45, 7.37 is a little more on the acidotic side than it would be if, say, it was 7.43, right? A little bit. So give it like a tiny little arrow, not a big arrow, like, ooh, we're acidotic, but just like a little, we're on the slightly more acidotic side. And we definitely know that we have our CO2 is low, right, is down. So we've got two downward facing arrows. So metabolic's equal. So if they're moving in the same direction, it's a metabolic problem. So we know that this is a metabolic. We know it's acidotic because we see our pH is a little on the lower side, even though it's normal. It's a little more on the acidotic side, but it is fully compensated. The lungs are doing their job completely to blow off CO2 to get that pH back in a normal range. Okay, so great job. Let's talk a little bit about some of the common causes of each. All right, so for our respiratory acidosis, again, this is where I think of our narcotic overdoses, right? They stop breathing and then that CO2 starts to build and they become acidotic because it's inadequate ventilation that's leading to that CO2 retention, okay? So respiratory depression. Asthma, you're not able to actually move air. So the CO2 is not able to get out. And so it starts to build. COPD, same thing. And then iatrogenic. So we put in poor vent settings, you know, let's say we've got a patient that is DKA, they get intubated. Their pH is 6.9. And they've been, because they're in such a horrific metabolic acidosis, their ventilation has been, before they got intubated, say 35 to 40 breaths a minute. I mean, they were chugging, right, to blow off as much CO2 as possible because of the severe metabolic acidosis that they're in. Key over to the next slide, metabolic acidosis causes, you can see DKA right there. But so let's say we have that patient, we put them on a vent, and now we put them on respiratory rate of 12 by a tidal volume of 400. So we've dropped their minute ventilation exponentially. So instead of breathing 30, 40 times a minute, they're now breathing 12. Okay, that CO2 is going to start to build up. So we can put them in a worsening respiratory acidosis or a respiratory acidosis of a primary cause just by having poor vent management. Okay, metabolic acidosis, some causes. So you've got either an increase in your acid production, right? Or a decrease in your excretions. The big thing in metabolic acidosis, when we're talking acidosis, is DKA, lactic acidosis, and an aspirin overdose. Aspirin overdose gets forgotten, but my God, the amount of challenging vent management that can happen with that patient, severe metabolic derangement. So it's something that you really need to keep in mind. We need to make sure that we appropriately support their ventilations if they get intubated, like I was talking about with the DKA patient, because we can actually make the entire process significantly worse by taking over their ventilatory status and not compensating enough for them. Our bodies are incredibly smart, and when they're trying to do a compensation for an acidotic or an alkalotic state, they tend to do a better job than we do. So we want to give them the opportunity. So that's why it's usually a big no-no to intubate DKA patients, right? Unless they're in extremis and they need to be intubated, because their bodies are so good about keeping that CO2 level down so that they can try to blow off as much acid as possible and get that pH somewhat in the best direction. So in a lot of these, the best thing we can do is medication and symptom management. Respiratory alkalosis. Now we're talking about the alkalotic side. Hyperventilation, okay? So this can be anxiety, panic attacks. That's kind of the traditional sense where people would breathe into the paper bag because it would retain CO2 and they'd be able to rebreathe their CO2 so they don't keep blowing it off. Pain, because that increases your respiratory rate. You can actually blow off quite a lot of CO2 when you're having pain. Hypoxia. So if you are, breathing too quickly, too fast, you're not actually able to have any appropriate gas exchange. And then again, iatrogenic. We can cause it with the ventilator. We can overbreathe for people on the vent and drop their CO2 so incredibly much that they become alkalotic. And then our metabolic alkalosis. This isn't something that we see as frequently, but there's a decreased amount of hydrogen ions, and we have an increased bicarb, which is what's leading to that higher pH, right? Because bicarb is basic, higher pH. So vomiting, oversuctioning the NG tube can happen, especially more in your long-term patients, less so much in the ED is it going to be an acute problem. But if you had a patient that was upstairs in the unit for several days and they were continuously suctioned via an NG tube, it can become a problem. To be diuretics, or again, iatrogenic. There's usually always something that we can be causing. But either with medications or diet, we can have some challenges there. So these are kind of your most common causes. So things to think about if you have a patient come in and say, they're in respiratory depression, you kind of in the back of your mind are like, they may have a respiratory acidosis that we're going to have to end up treating. So what is all the rest of this, right? You get a whole printout and it has more than just pH, CO2, and bicarb, right? So let's talk about our PO2, okay? So it's not the same as what you have on your monitor. It's not the same as an SpO2. And what it's doing is it's trying to measure how much oxygen is in that arterial blood, but it reflects how well the oxygen is moving from the lungs in through the tissue. And so normal is usually about 100, but it's not 100% like with an SpO2. Normal can be anywhere from 75 to 100 on room air. But what happens is if you're on supplemental oxygen, you need to times the amount of FiO2 that you are on by 5, and that's roughly what your PO2 should be. So for an example here, you can see if you're on 80% FiO2, right, then you would expect with normal, healthy, well-perfusing lungs and normal cardiac compensatory mechanisms, right? So like your blood pressure is normal enough and your heart rate to be able to circulate that blood and circulate that gas diffusion, you would expect your PO2 to be about 400. Okay, so that's why when you see a patient that's on 100% of FiO2 and you do a gas and you see that their PO2 is only 100, and people think, oh, that's great, like they're at 100 and I'm on an SpO2 of 100 and this is great. It's not actually great because the tissue perfusion is really poor because it should be about 500 if you're on 100% of FiO2. So there can be a clue to you if there's a shunting problem, if there's a VQ mismatch, and we can talk about that in another video. But that is what that number means. So on room air, 75 to 100 is normal. And then that's another thing that's kind of confusing when you actually look on the printout and it tells you what the normal ranges are. It'll only tell you what the normal ranges are for room air. So you have to do the calculation yourself, taking your FiO2, multiplying it times 5, and that's roughly what your PO2 should be on your ABG for your patient if their lungs and everything else is healthy and compensating, working the way it's supposed to. Okay, and our base success and base deficit. I think this one's kind of an interesting one. So normal kind of varies. So you can see here, I put normal as -2 to +2. On the slip of paper here, it's -3 to +3, but roughly in that range is what's normal. And if you have a base excess, then you've got too much base. And if you have a base deficit, then you have too little base. And it's kind of telling you how much base you would need to get back to normal base deficit or a base excess. So what does this actually mean? Why do we care? The best thing I can tell you is that this tells you how bad your metabolic involvement is. And that's really it. So if you look at this gas and you see -11, then you know, yeah, okay, I'm metabolically involved. My kidneys are definitely involved, and they've taken quite a hit because I'm well outside of the normal range. So I know that it's going to take me a little bit longer to get this metabolic acidosis resolved and get back to normal. So this is just a really quick down and dirty way to see how involved that metabolic process is. And you don't have to do any fancy calculations. You can simply look at it and say, oh, wow, -11. Okay, I definitely know that this is something that's been going on for a couple of days and it's going to take a little while to reverse, but I know that this is metabolic related and the kidneys are involved. And so I want to be a little bit more aware of what else is going on with the patient and make sure that I have the right diagnosis. So there's a lot of great information that you can get. And on some gases, you can actually get a basic set of labs, electrolytes, HMH. Some of them actually have lactic acid on them, which is pretty cool. So definitely next time you're at work, see what the options are on the printout that you get. And then as you have patients that have gases done, to look at them. You know, ABGs are really kind of interesting. You know, if you run a VBG, most of the information is about the same. So your pH should be fairly comparable. It's going to be slightly lower on your VBG because it's venous, right? So the venous blood is returning. So you're going to see things like your CO2 is going to be really low in your venous because now it's returning and your CO2 is going to be high because it's returning the CO2 back up to the lungs and it doesn't have a lot of O2 to return to the lungs versus arterial. You should have a lower CO2 and a high PO2 because that is oxygenated blood that's moving out and it doesn't have that high amount of CO2 yet from that diffusion at the vessel. So it's really interesting if you start picking through and kind of seeing how your ABG relates to your patient. And then there's a lot of interesting information out there about vent management when it comes to ABGs and how can you appropriately ventilate your patient to make sure that you're blowing off enough CO2 or conversely potentially retaining CO2 depending on what their primary problem is. So definitely talk to your RTs, reach out to me if you have any other questions and we can talk about it a little bit more. I have a bunch of practice ABGs that you can go through. So if you ever want to do any more practice ones, let me know and we can kind of sit through and work through them. But it's definitely a great skill set to have if you can look at an ABG and kind of quickly tell what's going on with your patient. It cuts down your differential a little bit so that you can figure out if we're respiratory or metabolic, what the primary cause is, and it's going to help you to feel a little bit more confident in what you're doing. So thanks so much for listening, you guys. I'm going to stop sharing the screen and I'll see you next time.